All right, good morning. We're going to get going just to stay on time here. I want to thank everyone for coming to this week's MSK e-lecture. This is an e-lecture series that's being provided for educational purposes only. Just a quick couple of reminders. All the interactive features have been disabled to ensure optimal quality for all viewers. If you have any questions for the speaker, please email this email address, Emory MSK Radiology at gmail.com with any of your questions or comments. Our speaker today has kindly agreed to do a question and answer at the end, so please feel free to send those questions in. We will be recording this video and it will be posted either on the YouTube channel or on a different platform. Information about this will go out on social media. Attendees have not been given the right to personal screen record any of these talks on this e-lecture series, as it may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. I just wanted to also highlight, this was a talk, this link here, if you have a chance to write this down. The speaker today, Dr. Avneesh Chhabra, who I'm going to introduce in a moment, gave an excellent talk last week on hip imaging. And so this is the link to that video feed. If you haven't seen it yet, I would strongly encourage you to check it out. So with that, I'm just going to do a quick introduction on our speaker today. Dr. Avneesh Chhabra is an associate professor of radiology at the University of Texas Southwestern Medical Center, where he is the chief of the Musculoskeletal Radiology Division and the MSK Fellowship Program Director. He's a funded researcher with many focuses, almost too many to list, but primary interests include 3D sports imaging, 3D and diffusion imaging and MR neurography, sarcoma imaging, and rheumatology imaging. He's actively involved in driving innovation in terms of image-guided pain management and runs an MSK patient care clinic where he uses his diagnostic and interventional skills to translate his work into improved patient outcomes. Dr. Chhabra has received numerous awards and serves on many local, national, and international committees, including the RSNA Grant Review Study Section and Review Panel for Radiographics. He's published over 250 peer-reviewed articles, 2 textbooks, and 30 book chapters. Avneesh is well known in the international lecture circuit, and his educational material has been in hot demand during this pandemic. As I mentioned before, just this last week, he gave an excellent talk on imaging hip disorders. The link is down below. We're delighted to have him speak in our lecture series and thank him for taking the time to do so. With that, I'm going to turn this over to Dr. Chhabra.
All right, good morning, everyone. My screen is visible, Adam?
Yes.
Okay, great. So thank you so much for the invite for this series. I think it's a wonderful series. I've attended the other lectures from Dr. Morrison, Dr. Humans, and the recent one from Dr. Resnick. It's very well organized, so congratulations to the whole team at Emory. So this talk today is on diffusion-weighted MRI for bone and soft tissue lesions. So it's an extensive talk because I put together whatever is useful from DWI and my experience, and the literature talks about for over a decade worth of use of DWI in MSK. So we'll go through all those details. Let's see. So these are my disclosures. I have no conflict of interest. So I know you asked me to talk about MSK Clinic for a few minutes. So I'll take about 5 minutes about what we are doing with the clinic. And the first thing is, how did we all start that? This started in around 2014, I think 6 years ago. The reason it was started was when we were making all these diagnoses on MR neurography, the patients went back to neurologist or neurosurgeon, and then sometimes they didn't have the treatment for them because they didn't do image-guided procedures. Or sometimes they went back to primary physicians who send them to orthopods send them to spine guys. So it was like patient was running around after make all these diagnoses. The second advantage I had was I was a family doctor when I was in India for my family. Anybody who had dengue, anybody who had malaria, even cancer, they came to me. I sort of helped them with staging and what the treatment possibilities are. So I was pretty well versed with what goes on in patients' body when they're suffering. And these patients were coming from all over. There are some coming from Canada. I saw patients coming from Australia, and for neurography. And then I would see them before and after. Then we had to figure out, how to bill for that. So first of all, it requires support from your administration because you are a radiologist in your department. right? How can you run a clinic? And there's competition from other providers. So our chair was very supportive. So I congratulate Dr. Rofsky. He was very supportive. He said, if you want to see patients, yeah, go ahead. It requires courage and preparation. So I had to watch a number of YouTube videos, go back and see how to do a shoulder exam, hip exam, all that. So there are a lot of family practice sites out there, UK sites. And I had time to do, because initially when you join as a division chief, you have 50% time off. So I had some time off to bring new services or build new programs. And now at this stage, it moved from was called as MSK Radiology Clinic to Radiology Outpatient Coordination. Now it's called the RAD Clinic, because we have now multiple divisions participating. We opened a full-fledged clinic this year in Southwestern. It requires buy-in from your faculty, because not everybody, people become radiologists because they don't want to see patients. They don't want too much interaction. A lot of people are like that. But now there's a push from ACR, push from societies to talk to patients, see patients, interact with them. So you need buy-in from your faculty that you can slowly steam them in, step-by-step approach, baby steps, like show them. So I usually take my fellows with them, with myself, or take other younger faculty, show them how we are seeing the patients. And ultimately, you may think that you're losing money, that you're losing RVUs when you go there. It's actually not the case. 1 hour visit when I was doing, you get paid $250 for a comprehensive visit. And follow-up visits, half an hour, 45-minute visits, you get paid. That's number one. Number two, you order imaging for them. And it's not self-referral, it's like cardiologist. Like when patient shows up to them and they have to evaluate, they do cardiac echo. So you can order imaging for them, you can interpret, follow them up, do intervention. So it brings in a lot of money. It's like mammography. Screening mammography doesn't pay much, $20 or whatever, but it brings in all these procedures. So that's something to keep in mind, that when you're building this clinic. Next thing is that you want to have buy-in from administration to have a PAC station there in that clinic. So when you're not seeing patients, you can read studies. You have to coordinate with your billing, coding, and scheduling people. So right now for the new clinic, I'm in the process of building what's called service blueprints, where say if you went to a restaurant, right? Somebody greets you, somebody brings water, then someone shows up with the food menu, then you order food, finally you pay for it. So that's called service blueprint. So you have to build that service inventory for that blueprint, basically, that we are building right now, how they get scheduled and coded and all. And till now, I've seen about 400 or so patients. So what's the scope of patient conditions? They started with neurography, then patients, when they see you that you're running a clinic, shoulder pain will come, knee pain will come, calcific tendinosis for barbotage procedures, medial epicondylitis, all sorts of patients will come. So I've seen all sorts of patients. And then what you start doing is reverse referrals, meaning you saw a patient and it's a surgical case, somebody came for a fracture, you went to the clinic, you send it back to the orthopod, or someone who has a complex issues and you can identify the psychological issues, their pelvic floor pain, and they're coming for pudendal neuralgia or sexual issues. You can start engaging at that point your pelvic floor therapists or PT in that, PT and the psychiatrist group out there. There's a whole multidisciplinary group. And the other thing which happens with that is people, when they know that you have a clinic, it's an opportunity for you also, in the sense that when they're going to do a surgery for genitofemoral nerve or some sympathetic block or whatever, they'll say, I can do it in my clinic, but I want a second opinion. I want a radiologist to do it. So they'll send you patients also. But obviously there's an opportunity cost. If you're doing something, you're losing on something. I may lose on some RVUs. So for division chief, they don't count that RVUs that much, although I'm usually above the median. But there's an opportunity cost. When you start seeing patients, you're going to lose on some RVUs, and you have to be just efficient. It depends on your personality. If you can do it efficiently, productively, you can do it, but it's well worth it. It's good for your patients. And then they post on their Facebook, they have their blogs, pudendalhope.org or whatever, and they'll talk about you. They'll say, Chhabra does this, or he helped me. You go there and see him. And then you start saying, I'm at a position where I don't want to see all these patients for 5 days a week. What should I do? Again, you got to delegate. You have to train your juniors so they can see patients. A simple example is When I started MR guided procedures in Hopkins with Dr. Carino, we were doing it together, and Jan Fritz was a student at that time, a resident at that time. So we started that. When I came to Southwestern, I converted all of them to CT because it was much easier, quicker, faster. I could see all the nerves on CT. And when we did that, initially I put those CT guided injections on my days, 2 days a week when I work on the university side. And then slowly I trained all my juniors, and now everybody does those injections. So they're 5 days a week we're doing them. And similarly, you can do with the clinic visits. Initially, they all come to you. You make yourself unavailable for some days, and then have your juniors see them. And now I'm training RAs. So there's PAs and RAs. So physician assistant sees the patient, and we only go there for 10 minutes. The rest of the time, physician assistant answers the question. Now he's doing all the televisits and all that. So basically, you have to use your house staff, your PAs, RAs, your junior attendings well. So they also learn during the process. So that's how it's running now. And our next phase is going to be all the cross-sectional procedures which come to UT Southwestern. They actually come as consults. They don't come as orders. So when they come as a consult, the PA sees the patient, they check the labs, they check on the patient, talk to them, answer their questions, and do a follow-up visits. So that's going to happen from September. So basically everything will become clinic visits except the simple joint injection and fluoro-guided arthrograms and things like that. So that's how where we are in MSK Clinic. If anybody needs more details about coding, etc., I mean, you have my email there, and we can answer more questions. Okay, so let's go over this DWI talk. So we'll discuss principles, technical considerations of DWI and DTI, what they are. What are the normal and abnormal appearances of musculoskeletal soft tissues, bones, muscles, nerves, etc. Role of ADC in benign versus malignant lesions, grading of tumors, infections, inflammations, role of DTI in rectography, neuromuscular lesions. So this whole talk will basically cover everything you could imagine in MSK at the current time. We'll discuss artifacts and imaging pitfalls in last couple of slides. So what is DWI? So DWI is a functional imaging to measure the Brownian motion of water diffusion at the microscopic level. So if you can think of bulk flow like angiography, so that was done with phase contrast imaging for the veins, where you apply bipolar gradients from either side and subtract the images, and whatever is moving will not have much, will not subtract out, and whatever is not moving will subtract out. So you could see the veins. So similarly, in diffusion, you're doing that in a small voxel. So you're looking for protons themselves rather than just the bulk flow. And that Brownian motion shows up. It shows up as higher ADC values. If there's less motion, it will be less ADC values. So basically, DWI is sensitive to micro diffusion of water within the intracellular and extracellular spaces. So you're looking at a cellular level rather than bulk flow. So it basically gives you an insight into the pathophysiologic state based on how much it's diffusing, which direction it's diffusing. All of that information can be derived. So we have stationary water molecules, which are unaffected by the bipolar gradients, which are opposite to each other, and hence they retain their signal, while moving water molecules are not rephased by the second, and hence they lose their signal. So anything which is moving, like if you can imagine brain imaging, anything which is normal brain will appear dark on DWI. Anything which is stationary, like brain infarct, will show up as white. So let's go through some technical considerations. So this is where we have free diffusion, or relatively free diffusion, or less cellularity, or simple fluid, or fluid in a pond of water. You'll have increased diffusion. While here we have restricted diffusion, which could be pus, could be lots of cells, could be architecture of the nerve or cartilage, with like a lot of organization where there's less movement. So there'll be less diffusion. So how do we calculate ADC values? Well, first of all, you have to apply the diffusion moment. That's called B value. So higher the diffusion moment you can apply, more diffusion weighted it is. And if you look at from the prostate literature and other literature, people started to do up to 2000 B values. Or sometimes you can interpolate on the softwares like Synovial or some other software. You can sit down and you can interpolate whatever you have acquired as 50, 40, 400 or 800 B values, you can interpolate to 2000 B values. Is that very valuable? It hasn't been shown so much. But usually people say if you reach up to 1000 B value or so, it works out pretty good in small structures. In MSK, usually by 800 B value or so, you get most of the stuff you need. It's pretty accurate. So signal intensity on DWI can be looked at, and that we look at routinely for our nerves, for our bone lesions. These things become very conspicuous when they have restricted diffusion. ADC helps us, apparent diffusion coefficient, for quantitative analysis. And you can see these curves. More points you have on the curve, the better reproducible that curve would be. But you need at least 2 points to form a curve. And this is exponential ADC or EADC. That map also can be generated. I usually don't look at this. I usually look at the main ADC map. Timing. Some people will advise you that do DWI before IV contrast to avoid perfusion effects. That's what we were doing before. But what happens with some of the scanners which are not so reproducible, say some Philips scanners, we have older scanners, their techs will do DWI before other sequences sometimes, because that's how it's listed in the PDF. When they do that, lots of DWI maps fill up your packs. And then the clinician is looking at it, he's trying to find the post-contrast image, and before that, you have 50 diffusion maps sitting there. So balance with what your clinician wants. So recently, we have moved all of the DWI after IV contrast, and we haven't noticed any change. So I think this is a good strategy. Basically, do your T1, T2 contrast, and do DWI as your last sequence. And as long as you have higher B value, you won't get those perfusion effects. Which plane is best to do? Well, axial plane is best to avoid ghosting artifacts. Keep the zero interslice gap. What that does is you can reconstruct these DWI images in coronal and sagittal and see nerves or larger structures or whatever in different planes. Now, for last few years, I would say last 4 years, we have been using Resolve imaging, which initially came in brain. Now it's available on the Siemens scanners on for other areas as well. So we use that for feet, we use that for toes because there are a lot of susceptibility artifacts there. So what this is basically, it's less, in nutshell, it's less case space filling. So how do you do that? Well, the case space trajectory is divided into multiple segments in the readout direction. And that allows for a shorter echo time. And the echo time, as much as it's closer to the structure you are evaluating, say a nerve or a cartilage or whatever, it's better. So generally in most DWI images, you'll get to a echo time of 80 or 90. If you have a good scanner, you can get down to 60s. So the smaller you can get, like the Prisma scanner from Siemens. So that one is like a diffusion machine. There you could get to between 50 and 60. The smaller you can get, the better signal you can have and better DWI imaging you can get. So it ultimately, Resolve leads to better image quality, less image blur. It has less SAR, less susceptibility and motion artifacts. And you can do it in any plane. You can do it in sagittal or coronal planes. B values, again, choose a range of B values between 0 and 1000. And more than 50 to 100 basically will avoid the perfusion effects. So the lower B values have higher signal, a nicer image. The higher B values is not so good image, but is better for lesions. Fat suppression, we don't use frequency selective fat suppression. We either use stir or spare. I use spare in most cases because it's a higher SNR than stir. So that gives us the best fat suppression, because if you don't have a good fat suppression, you get a lot of ghosting and you'll degrade your DWI imaging. Scanner, it's easier to do on 1.5T imaging, but by employing parallel imaging, reduced echo spacing, which reduces your noise, and you do better off-center field homogeneity with newer 3T scanners, the artifacts are lessened. So we do both DWI and DTI on 1.5T as well as 3T. They work out pretty good. So technique, most of the time we use a single shot EPI. Now I've started a grant on, I'm working on recruiting patients for jaw nerve imaging. And that's an area which is face, where there's no good coil, no real good coil for the lower end of the face. And there we are moving more towards the spin echo type TWI and DTI, but that takes a long time. The multi-shot EPI and spin echo, if you start to do DTI, that takes a long time. If you do a spin echo DWI, that's not so long. So when I last time tried multi-shot EPI, my EPI 4-minute sequence became 15, 16 minutes. So you don't have really that time unless you're a grant. But it reduces distortion, ghosting artifacts, and susceptibility artifacts. Obviously, the scan time will be increased. Now, in terms of modeling, there are different types of modeling, mono-exponential, multi-exponential. We usually use what's available on the packs for simple ADC calculations. I really don't have time to go in the clinical practice and do all that. That's more in research arena if you want to do Q-space imaging, multi-exponential and all that. DTI not only tells you what's moving or not moving like DWI, it tells you the direction also where it's moving. So to find that direction, you need 3 points in the space, 3 coordinates. So how do you get those 3 coordinates? You got to have bipolar gradients in at least 3 planes. That means you need 6 gradients, so 2 from each side, right? So one of my collaborators, Dr. Gustav, I don't know if he's online, he basically did a study some time ago, I think it was published in AJR 2011 or 10, where they found out that if you go above 20 directions, you don't gain much for MSK imaging. And the structures are simpler as compared to brain. So I usually use medium number of directions since I started it in 2009. So I usually use 12 directions. On Philips, it's called medium level of directions, or 15. On Siemens, it's 12 directions. So usually 12 to 15 are good enough. And then there you can derive isotropic versus anisotropic diffusion, meaning is the diffusion free everywhere where you have FA value of 0 versus completely restricted in one direction, that FA value of 1. Most of the MSK structures are between 0.5 to 0.7. And when you get to lower FA values, say 0.3, 0.2, you know there's degeneration in the nerve or degeneration in that tissue, more fluid content, loss of normal architecture. While when the FA value starts to go up, that means there is some regeneration happening. So that's a simply defined. So finally, this is, you'll have this lecture available to you. I asked it to be recorded. So you'll have everything there. So these are the parameters we use, but I basically discussed all of them. One thing I want to mention is bandwidth. So bandwidth is the ear of the magnet, what's coming out, and the receiver is listening. So higher the bandwidth, better it is for DWI. And say for 1.5 Tesla, the bandwidth will be about 300, 500, while for 3 Tesla, you're looking at about 15, 1600. But there's a sweet spot. So what you have to do is you look at your DWI and try to manipulate the bandwidth and check echo spacing. So there'll be a sweet spot of about 1600 or 1560 or whatever, where you'll get your lowest echo spacing. That's the point you want to choose for your DWI and DTI. So try to manipulate that. Finally, image processing, you can do color coding. I'm going to show you some images. And keep your filter setting at about 10 to 20%. So filter reduces the noise around the image. But if the filter setting is at 0, it's too much noise, but you don't lose anything. So I usually keep it about 10% or 20%. But if you keep the filter high, say 50, 60%, half of the image is cropped up. So some of the ADC images which come out will look like that high filtered, cropped up image, and you may lose signal and you may not know where to measure and all that. So keep the filter at about 10 to 20%. For tractography, keep the angle around 45 degrees, minimum threshold of 0.1, and fiber length of 5 to 10 millimeters. If it's a small nerve, say I'm looking at jaw nerves, I usually go to 2 millimeter also, fiber length. Okay, that was enough for theory. I'm going to show you lots of images. So here is a T1 varied image, right? And here are the different B values, 50, 400, 800. And you can see there are vessels on B0 or B50. And as you go higher up, those vessels get suppressed, right? And the normal nerve, sciatic nerve, is gray. And here you get the ADC map where the muscles look slightly whiter. They're grayish, but slightly whiter. You can see the vessels, the fluid in the vessels. And then you can just simply draw it and take a mean value. I usually rely on mean value. I know for research, we report minimum values, maximum values, but usually the mean value is what we look for. It could be whole lesion value, it could be whole area value, or it could be an area which appears to be low ADC, but we want at least 1 centimeter area, such area, and do multiple measurements to make sure that you're looking at that area correctly. Now there's something about metal artifact reduction. Jerry Wang, in our setup, he basically came up with this. He said if you put a permanent magnet outside the brain or outside the face, that's going to attract all the stuff from the metallic stuff you have in your body. So if you have dental hardware and things like that, this will attract all that artifact. What ends up happening is the bad diffusion becomes a good diffusion. So that was quite innovative. So right now we're working in the spine area. How can we reduce metal artifact in the spine? Okay, these are the normal ADC values. They're well published. Again, you can take a screenshot, but it'll be in the lecture. But we'll go through all this. So yellow marrow obviously has fat. It's going to have low signal intensity, low ADC. So in fact, what I'm going to talk about in DWI for bone marrow and fat is going to be enhanced diffusion. It's not restricted diffusion. So normal diffusion values are low. If you can look at here in the skeletal muscle on 1.5 T, it's 1.3, on 3 T, it's 1.5 normal. But if you go to the marrow, it's very small value, or red marrow, it's very small value. You know, these will get enhanced as we get marrow issues. And when it's more cellularity, they'll drop back again. So you need to know that spectrum. We'll go through that. And then when patients are on GCSF or erythropoietin, which is stimulating the marrow, it'll even lead to narrower signal differences between red bone marrow and malignant infiltration. Okay, so here we have fatty marrow, and here we have a patient with metastasis. Well, you can tell here that there's fat here and there's bone erosion along the endosteal surface with a big mass lesion. And that becomes enhanced diffusion, meaning normal marrow is black, and now you have enhanced diffusion. But if you look at ADC, it's 0.8. So look at the brightest areas and look at the ADC. If that bright stays bright, well, the edema stays bright, but the tumor does not. So you know it's a malignant tumor. So anything below 1.1 is bad for us. So here is ADC of 0.8, so we're thinking of malignancy. Now here's a red marrow. You can easily tell on this, and you can create these color maps. So remember this picture when I show you bone images for infection, the bone appears blue like this, right? The muscles have a little more diffusion. So this is 1.5 here, red. So you can see the muscle is red. That's the muscle diffusion normal. And bone is low, obviously. It's 0.4 ADC. So let's look at bone tumors. Well, let's learn systematically. You're not going to read diffusion in isolation. You need to have these plain films, the conventional images, and then use diffusion as an adjunct. So remember, the best research which comes out in any JM or wherever, it changes 1% or 2% of what you do. It doesn't change everything altogether. So diffusion is not going to change everything altogether, but it's very useful. So every time a tumor is coming from outside, I'm looking at it, or infection or whatever, I'm looking for those ADC images because it adds up by small amounts, not too much. So remember that when we go forward with this. So radiographs are most important. So here you have a unicameral bone cyst, an ABC, a giant cell tumor, you know all this. And you have typical MR appearances. Here you have osteosarcoma, chondrosarcoma, which is bright, right? And you have a giant cell tumor, which are dark, and then chondroblastoma in the epiphysis. So you have learned this from Dr. Murphy and all the experts who are out there. They've been teaching it for years, right? So this is easy stuff. Even this one now, here, you know, in the fingers, you get enchondroma or getting outside echondroma, chordoma in the tailbone, or osteoblastoma. More than 1.5 cm is osteoblastoma, less than 1.5 is osteoid-osteoma. So anything in the pedicle, you're looking for osteoblastoma or fluid levels of ABC with these artifacts caused by the fluid level. So these are easy. Where we get into issues is when we start to see images like this. So here, the bone looks pretty good. The joint looks bad, bone on bone. And you can see bone on bone here. If you look at the marrow, and I compare to the muscles, it's kind of iso or slightly darker than the muscle. Now I get into issues, you know. When you read about marrow, people say, oh, when it's iso to muscle or darker to muscle, you got to worry. But in this case, it's limited to metaphysis. It's not involving epiphysis, not so focal. So my suspicion is low. But can we rule out bad pathologies just on the basis of this? Well, before you move to diffusion in these cases, you got to look at chemical shift imaging. And a lot of people, including myself, have published a bunch of stuff on this. But basically, if the marrow becomes dark on out of phase relative to in phase, you're good. It's benign marrow. And this is T1 CSI. So when I moved to Southwestern, I had one thing in mind. I said, you know, I was at JHU, we would call these patients randomly at 1 or 3 months, like every 1 or 3 months, you know, somebody will come up with this marrow and will call back for CSI and all that. And I typically don't need a T1 weighted imaging. I only need it for tumors or infections. I don't need in my ortho protocols. So how can I avoid calling patients back who came for a joint pain and now you're suspicious of his marrow? So I put this chemical shift imaging in all the protocols. It was only a 2-minute sequence, T1 in and out of phase. Every scanner had that availability. And I tell you, in last 6-7 years, I've never called a patient back if you have this in your protocol. Now, recently in last 3 years, we have moved to T2 Dixon imaging, and we actually evaluate the patients who had T1 and T2 Dixon imaging both. And we found that on T2 Dixon imaging, effects are even more remarkable, that you lose, up to 20-30% signal on T1 weighted imaging. On T2 Dixon imaging, you in fact lose more, 50% signal in the red marrow. So you lose a lot of signal. So they are as good as T1 weighted images. So now we have gotten rid of all the T1 images. We just acquired 3 plain T2 Dixon, and we're done with the ortho protocol, because you have your in this case, there's a little motion, but you have your cuff evaluation, fluid evaluation, marrow evaluation. So these are the T2 Dixon images, and you can see it also presses out pretty nicely. So these were the results which one of our students did a research with me. She's resident now, and it was presented in, I think, SSR meeting also. So here you can see, when you look at the signal loss, it's much more in red marrow. It's a little less in yellow marrow. It's even less in benign tumors, and malignant tumors even much less. So everybody loses something, but basically this is close to zero. So malignant tumors do not lose much. And this is the decision tree we built up, and basically shows that in red marrow you lose up to 50% of the signal, right? In yellow marrow you lose up to, if you put a cutoff at about 26%, you have some confusion between yellow marrow and tumor, but you're not going to have that confusion once you have T1 weighted image. This is yellow marrow, this is tumor. So this is how the images look like. You have a tumor here which suppresses out on the outer phase image. You have a tumor here which does not suppress out. So this one is an enchondroma, and this one is a malignant tumor. Now, you can get confusion with these kind of tumors. So here is a tumor with a nice rim of sclerosis, right? And I know I sent it to OCAD some time ago, but basically it looks like enchondroma or something, isn't it? It's bright on T2 images, maybe tiny punctate calcifications or whatever, which we don't see on CT, but maybe something there. If you look at on contrast, there is enhancement of the lesion, some periphery, some inside, just like you see with enchondromas, not a real fibrocystic change, not near the bone. And then if you look at in and out of phase, it suppresses out tiny bit. And we have had many tumors like this, especially from prostate cancer. And my colleague, Dr. Thakur, may be on there. She had a couple of them last month. So then you get into a problem. Is it benign or malignant? It looks like enchondroma. Well, if you look carefully, there's edema around the lesion here. That's not good, right? So this was a renal cell metastasis, renal cell cancer. So we know that Dixon or CSI doesn't work if there is hemorrhagic lesion, if there are sclerotic lesions, and you can misdiagnose some benign cartilaginous or mucinous lesion. So in fact, you need the whole mumbo jumbo of diffusion imaging and T1, T2, everything, and contrast. So where is DWI useful? Well, first of all, if patient cannot get contrast. Secondly, even if they got contrast, most of the stuff enhances. So, does it become indeterminate because it's enhancing, or you can tell something more? So this is I'm starting with a very simple lesion, a well-defined zone of sclerosis, elongated lesion along the bone. As the bone grows, it grows back into diaphysis, starts in the metaphysis. So you can see this cystic area there on T2 Dixon. So water image, in phase, opposed phase. This opposed phase is very good, or out of phase is very good to find the margins of the lesion, or if there are any fractures, or if there is any internal stuff, hemorrhage, etc. So here you can see on the DWI, it's a bright lesion. ADC is completely bright, it's fluid. So this is a simple bone cyst, very easy. So ADC value of fluid is anywhere from 2.5 to 3. So here you have 2.7, benign tumor. And then obviously contrast was done because tumor was suspected, and you can see just peripheral enhancement, very easy. This one is also an easy lesion where you see this punctate calcification. It's a chondroid lesion, has some lucency around it. And here is that lesion on T1 images. Here's a lesion on T2 images, or T2 FATSAT. And then if you look at on diffusion ADC, it's a bright lesion. So most of the enchondromas you're going to see, they have very high ADC values, anywhere from 1.6 to 2.7, quite high. Some I have seen up to 3 ADC values also. So enchondromas are quite bright. Now you get into trouble with these kind of lesions. This one is going out across the bone. So is this chondrosarc? Is this juxtacortical chondroma? Is it some sort of non-ossifying fibroma or anything like that? But if you look at it here, it's echondroma. It's a chondroma in the bone cortex, right? So there's an echondroma, or juxtacortical if you want to call it. But anyway, that's all jargon. But what you're looking for is diffusion shows this white signal, ADC shows this white signal, and you're pretty sure it's a enchondroma or a benign cartilaginous lesion. And that's what it turned out. Now, problem comes when you have a lesion like this. Again, quite sharply defined, doesn't have sclerosis, but sharply defined. And if you look here, it's a hemorrhagic lesion. It has that bone fragment through it. So is it the trapdoor sign? You know, you look for fallen fragment sign, you look for trapdoor sign. Is the trapdoor sign or is something else happening? You look at on diffusion ADC, quite white, you know. So hemorrhage may affect diffusion values, T2 shine through, but in most cases I've seen if it's a recent hemorrhage, it doesn't affect much. So here you can see it's a benign lesion based on this. And then you do your perfusion images and you can see that there is some enhancement, but it's just gradually picks up and it's mostly around the tissues around that lesion. So it's the inflammation around the lesion, no real nodular stuff picking up or washing out. And if you do contrast, there is peripheral enhancement. Now you can see the little fragment also there, which we didn't appreciate before. And that's another fragment. So this is just a simple bone cyst, but this was a 65-year-old patient. So all of this helps. And here this was fixed. Okay, now we have another bone lesion in the same location. You can see there's lucency, again, quite well defined, you know, no sclerosis there. And you can see this bright lesion there. Looks like a hemorrhagic lesion again, and has some ill-defined edema or something around it. We do contrast, it shows peripheral enhancement. And if you ask people, then they say, oh, you know, it may be a hemorrhagic cyst, so it can be a tumor, we don't know. Again, it's an older patient, you know, there's already rotator cuff changes, you can see the narrowing, bony hypertrophy, etc. If you do the DWI, you can see this bright lesion and really dark. That's a high-grade tumor. This was a bone metastasis. So pretty easy call. So every time somebody asks me for tumors, I'm looking for this ADC image. So it's so helpful. Now here is a different kind of tumor. It extends to the epiphysis, which giant cell tumors do. It's expansile, it's so bubble. It's quite dark. And dark tumors we equate with giant cell tumor, and that's how it should be. And if you do contrast, they show heterogeneous enhancement where you can say, oh, is it giant cell sarcoma or something else I'm dealing with, you know? If you look at perfusion, it sort of picks up and stays on. If you look at perfusion maps, it washes in a little bit. Equilibrium, it gets a little bit of contrast in there. In the washout phase, not much washing out. There's an area under the curve. So overall, it gets perfusion mostly along the periphery in 1 minute or so. It basically gets, you know, a little bit of perfusion. So more we saw was kind of delayed. You know, that image is the one I showed you before. That's at 3 minutes of time when there's more perfused in. So that all indicates this is a benign tumor. And if you look at DWI and ADC, so these will be dark tumors. So that's something published by my colleague, Dr. Oganis, who may be online. Basically, he published on giant cell tumors of bone and soft tissues. They all have low ADC values, but to start with, they are lowish also on the DWI. So that's a good thing that can help you with giant cell tumors. Now, osteosarcs like this, big ones, showing the lesion on different sequences, very dark on ADC. You know, it's a high-grade osteosarc, very easy call. And you got to measure where the lesion is bright or where the lesion is enhancing, not where the fibrous tissue is, which is dark. Find the bright area, find the dark area, and then measure there. Or a pelvic tumor like this, you know, in this case, there are some calcifications here, right there, small calcifications, some scalloping of the bone. If you look at on the bone scan, not much shows up. If you look at on CT, there are these tiny calcifications there, so you can think of synovial chondromatosis. If you look at on MR, there is a little bit of bone involvement also, which is usually a bad sign. But you know, when I was looking at it, I said, oh, maybe still is synovial chondromatosis, and they can have a little bit of bone erosion and things like that. But you couldn't exclude, because it's in the pelvis, that there is chondrosarc or not. So we ended up calling it indeterminate. And if you look at on different images, it shows just this peripheral enhancement, which again doesn't tell you much in chondroma versus chondrosarc. If you look at DWI, it doesn't tell you much. So chondrosarcs, not so useful, because when you have grade 1 and 2, you have these bright lesions like that. When it's grade 3, you may see more of the dark areas, but grade 1 and 2, you can't tell. But it may help you if you have a chordoma or chondrosarcoma in the back and you're worrying, you know, what is that? So chordomas are usually lower ADC values, where chondrosarcomas are brighter. So it can help you with that. But usually DWI is not so helpful in chordoma versus chondrosarcoma. Then moving to this tumor, looks like, a tumor with hemorrhage, exophytic tumor. There's a hemorrhage you can see on the fat suppressed T1 image. On subtraction, there's not much enhancement. So what are we dealing with? Is benign lesion or malignant lesion? If you do the ADC, it's about 1.5. And that's what happens when you have hemorrhagic, very vascular lesions like that. Your ADC may not come down quickly. This is a renal cell metastasis. And here you can see the perfusion effect. So this yellow line is through the tumor. The blue line is through the vessel. Okay, so you can see it perfuses very fast and washes out also. So they're very vascular tumors, thyroid, kidney, melanoma, choriocarcinoma, they're like that. Okay, here we have thigh pain coming up. This is a recent case. I think last month we saw this. So my faculty was reading, and then they saw this heterogeneous appearance. So they're worried, is it sarcoma or is it myonecrosis? What's going on? We don't know. Patient came with thigh swelling and pain. That was the only symptoms. And this is, dual energy scanner. You can see the iodine map. There's some patchy enhancement there. Some enhancement in the bone also. If you look at the bone marrow edema map, this bone is all infiltrated. This is not a normal bone, what you're dealing with. So now if you look at on different images, these are your T2, T1, T2 Dixon, T1, pre-post. You can see there's a lot of necrosis there. So that's all myonecrosis. And this is typical, rhabdomyolysis, myonecrosis type picture with this streaky appearance. If you look at bones, this is a post-phase, in-phase water image. Well, it's not suppressing out. So we are worried. But if you look at on T1 image, could you make that diagnosis? Not at all, because this is brighter than the muscle. Could you make a diagnosis on T2 images? Not at all. It's not very white, it's not patchy. But you see the myonecrosis. Could you make a diagnosis on DWI ADC? Absolutely. Low B value, high B value, ADC. Look at this, totally dark. So it's really, really good to find infiltrative stuff, especially round cell tumors. It's excellent. So finishing up with bone tumors, enhanced ADC more so in benign lesions, less so in malignant lesions, renders the lesions conspicuous, identifies benign versus malignant or high-grade tumors and round cell tumors, increase the confidence level of diagnosis, directs the site for biopsy, and not so useful in chondrosarcoma. Okay, let's move to joint lesions. So we're going to discuss these 4 things. So whenever there is effusion versus synovitis, usually we rely on contrast. We look for some synovial thickening. Sorry, go back. We look for some synovial thickening and we look for enhancement, right? That's how we know synovitis. What will happen on DWI? On DWI, you have 2 areas here. So this area is simple fluid and this area is synovitis. And on synovitis, you're going to see this grayish appearance. It does not restrict badly. It just restricts mildly. But this enough is tell you that there is synovitis going on. And here is a case where we had this. This is the DWI. And on DWI, you can see this white stuff there. Sorry, these are all perfusion images. These are not DWI. So here you have area under the curve. You have wash in and wash out. And you can see not much is washing out. Quite a bit is washing in. And this is in 1 minute. Quite a bit of contrast gets in. This is on the perfusion MRA image generated from the same. You can see all of this synovitis there and synovial thickening, which is enhancing. And this is an arthroscopy. And all of this was PVNS, which was taken out. So diffuse PVNS. Now, if you go back on DWI, this is how it looked like in the hip. And this is how it looks like on diffusion ADC. It just shows this grayish, darkish appearance. And this is on perfusion, and that's on arthroscopy. Okay, that was an easier case. You get into these difficult cases. So this patient had surgery before for diffuse PVNS. Now we are looking for any residual recurrent. And you start to see this synovial thickening here, a little synovial thickening there, a little thickening there, a little thickening there. So there is some disease there. Now, how many foci? The surgeon is asking you. You have 1 focus here, you have 2nd focus here. If you look at on diffusion ADC, you can see the dark appearance, which you expect in PVNS. So that's not synovial sarc. This is just PVNS. And then if you look at contrast, yeah, there's some enhancement there, some enhancement there. That's it, right? Rest you cannot tell. These are subtraction images I'm giving you. And then if you look at perfusion, you can start to see multiple foci. So that's one, right? The one we are seeing at the popliteal fossa. That's one in the back. This one. There are more there. 1, 2, 3, 4. So there's so many foci. And as you get to the diffuse stage, here there's so many foci. So there's not just one. So you got to use these multi-parametric techniques everywhere possible. And these are free if you're giving contrast. You can run your perfusion, you can run your diffusion in 3 minutes and get that. Okay, moving on to spondyloarthritis. So in spondyloarthritis, these are a couple of cases I just put in there. We do diffusion in all of them. So here is a classic case where you have these end plate changes, your Romanus lesions. And the SI joints, maybe there's edema, maybe not. It's hard to tell, right? This is contrast. This is T2 images. So here doesn't look like there's much edema. And maybe there's tiny enhancement. We're not sure. You look at on diffusion, it's so easy. It's bright and it's enhanced diffusion. You can see in the sacrum. So that's an active case of spondyloarthritis. So we published that, a couple of articles recently on this. Okay, this was a case one of my fellows gave me. He was doing research on our spondyloarthritis cases. So this is a case of psoriasis. This is pre, that's post. This patient had at least 7 MRIs, and basically he wasn't on treatment. Although there was these clinical symptoms, they weren't sure anything in the back is there or not. And they were just treating with topical agents and some methotrexate and things like that. Well, what do we see on this MR? The SI joints, they're narrowed on both sides, but there's no activity there. And if you look at on diffusion ADC, no activity. If you look at trochanteric areas, a little bursitis, but that's commonly seen in many cases. When it becomes flame-shaped or goes into the bone, then you're dealing with enthesitis. Then if you look at ischial tuberosities, yeah, this one is active, right? You see the bright area, you see the dark area here. Now, if you look at on contrast imaging, which we do 3D imaging in these cases from L1 to lesser strokes to cover all the areas, you can see these areas of enthesitis. So again, these can be monitored, and over treatment, you can do the ADC values before and after. Moving on to cartilage, normal cartilage will show you restricted ADC. When you have chondromalacia, it will be increased. With fibrocartilage degeneration, it's going to be lower. Again, it's a subject of research. So this I published a few years ago. I haven't used much in the cartilage, but basically you can make these color maps, make it conspicuous. But on the 3D images, on the spin echo images, I see cartilage so well, small areas of chondromalacia and all. I mean, I don't need all of this for cartilage. Then moving on to the domains of infection and neuropathic joints. Well, when you have collections like this, you're not sure it's neuropathic or infection, although we don't have any ulcer to see. Sometimes they're pinpricks, so you don't know if they have any ulcer or not. But it's fairly easy. First of all, you look at on Dixon images, on the post-phase images, you'll see cystic changes, or you'll see these margins of the bones very sharply. So you're dealing with neuropathic and not an area of infection, which are ill-defined margins. Secondly, if you look at on the diffusion ADC, it's white and white. So now I'm going to show you lots of reds and blues. So red is basically high diffusion. Blue is going to be low diffusion. So this is high diffusion, it's benign. Moving on to infections, this is classic infection, very easy diagnosis, but I'm starting with the easy ones. So here you have an ulcer, bone involvement, and what I look for is what some of you do not look for. I know that because it's very little in the literature. You look for this cortical erosion. Okay, just don't look for this T1 darkening. That's a later stage. Look for this black line going away. So this is gone. Look at on T2 images, this black line gone away from there. So this black line is preserved. So that's where the erosion has happened. And look at on diffusion when it's just reactive edema versus more of the osteo. More of the osteo will have brighter signal. Reactive edema is less bright. So here is your reactive edema. As you go to the diffusion, you don't see much. And you go to ADC, on ADC, you will see that reactive edema, and you will see that osteo also, that gray stuff. And here the ADC is 1.3. You may have areas like this where it's osteo or no osteo. Here you have a big ulcer. And then here you look at the bone, and you sort of lose that cortex here, right? But there is cystic area here. So the question is, is that osteo already in the bone? It hasn't effaced that cyst yet. Versus is just osteitis without osteomyelitis, right? If you look at our diffusion images, you don't see much going on there. So whatever that cystic area is shows up, but nothing else shows up. And this was a proven no osteomyelitis. The other thing you look for is a ghost sign, and ghost sign was first described on T1 images in the foot literature, not radiology. I haven't seen any radiology, but I saw it in the foot literature, where you can see there's a collection there, and the bone actually shows up on the T2 image. On T1, it disappears, that portion of the bone. So that's called ghost sign. But it's so well apparent on DWI ADC. Here you can see that bright signal. You can see the bone disappeared, and here all the blue bones are there. I was showing you normal bones. Here the bone is gone. So that ghost sign nicely shows up on ADC images. Here's another one. You have all of these infected and all of these bones disappeared. Okay, so that's osteomyelitis. You can have intraosseous abscesses. So when abscesses are there, these are in a restricted small space, and they're going to restrict. They'll have these black sign on ADC. So white on DWI, black on ADC. So you can find these small areas of pus pockets. In this case, are intermittent toe infections, on and off antibiotics. So we don't know it's actively infected or not. So here, this is a tract where they did the biopsy, podiatry did it. And you can see this is DWI ADC. ADC is 1.4. So it's a little higher than what you expect for osteomyelitis. So this is basically partially treated. So you can follow them also. So we're actually doing a study right now through ADA, where we're following these patients before and after treatment, with biopsy before and also biopsy after. Now, here's a case of osteomyelitis versus infarct. So here, obviously, you have bone destruction. You have a collection there. And this looks very patchy. You know, is it something else or is it osteo? So if you look carefully, you know, it looks really weird. There are some metal artifacts also. If you look at on diffusion ADC, there are two different things happening here. This one is abscess. This one is not restricting. It's a bone infarct. And the abscess sort of reaches there, but this is not infected. So they can basically drain it out and scrape that portion. So one of my students, Ramis, he actually had an award from RSNA. So he presented in RSNA on this stuff. So basically, in normal tissues, you have low diffusion. With edema, it goes up really high. With cellulitis, it drops down. With abscess, it really drops down. Normal bone is here. With osteitis, it goes up, but there's overlap between osteitis and osteomyelitis. That's a difficult area. With an abscess, it drops down again. So you get these different effects of ADC, and these are different values. So again, you can look at them later. So here are some examples. So soft tissue edema, like that, doesn't enhance much. On ADC is very white. Cellulitis, little mixed signal. Enhancement. On ADC is grayish. And there's myositis with that. Cellulitis and myositis, again grayish. And here you have your values here. So this is about 1.0 to 1.3 like that. You can look at that value. Abscess or adventitial bursitis, how can you tell? Well, very easy. Look at DWI ADC. ADC is really dark. So very easy diagnosis. Versus adventitial bursitis is all white. Subperiosteal or intraosseous abscess. If you look for that, you know, here is again cortex gone. Okay, look for cortices on MR. Very easy to see. So here the cortex is gone. On T1 is slightly demineralized on that cut, or it's basically showing some gray signal. On contrast, look for enhancement of the cortex. So here, if you look at on DWI ADC, big abscess all around the bone. So that bone is infected. Now, extent of the abscess. When you have an ulcer, when you have superficial abscess, how deep does it go? You know, that's what clinician wants to know. Or is it just necrosis? Because a lot of times you'll see on subtraction this dark area. Is it just necrosis? It's an abscess. You know, you may say, oh, it looks like maybe there's a little collection there. Well, look at on DWI ADC. You can see every pus pocket going down there in every direction. Versus these kind of cases where you have hard time finding any abscess. You know, this is contrast. If you look at on DWI ADC, these are the pus pockets. Very easy to see. And the area which is closer to the ulcer is not going to restrict much. But remember this appearance, the pus is darker on the outside and less dark inside, where there's less restriction there. It's still getting organized. I'm going to show you a case which is opposite of that. So here is abscess or no abscess. Again, similar case. Maybe there's something, you know, it's hard to tell if there's an abscess. If you look at on DWI ADC, very easy. There's an abscess there, right there. Tenosynovitis versus bland diffusion. Is that tenosynovitis? Yes. Is there abscess in there? Hard to tell. This obviously looks like abscess. Now, if you do the DWI, this is all abscess, this black area. This is all bland tenosynovitis. Now, this is osteomyelitis with devitalized tissue. Actually, we are thinking of doing a study where you can actually measure the devitalized tissue. And what you look for that is opposite of that. So here, what you're seeing is white area outside, dark area inside. Okay. So that's basically devitalized tissue. It's opposite of what you're seeing. So darker on DWI and brighter on ADC. Dry gangrene will be dark and dark. Basically everything is ulcerated. So this again, you can look at this, but basically simple fluid will not restrict much. Abscess will restrict. Others, hemorrhagic stuff and all will become grayish, or sometimes very organized hemorrhage that will be dark. And then dry gangrene will be dark, or fibrosis, calcium, etc. Okay, moving on to soft tissue tumors. So soft tissue tumors, basically, again, many lesions are pathognomonic. Parameniscal cyst, or a ganglion cyst, a vascular malformation, a muscle hypertrophy mimicking a tumor. I mean, all those are pathognomonic. You don't need stuff, more advanced imaging for that. But when they are coming through a tertiary center with, multiple scanners, imaging coming from everywhere, when it's suspected tumor, we just do a tumor protocol. We don't have people to monitor and say, oh, this is contrast needed and not needed. Although we protocol all of them in the beginning. Now, problem is you have these small lesions which are enhancing. This is in the median nerve. This one is in the soft tissues. This one is synovial sarcoma of the median nerve. This we published in Skeletal Radiology. This one is an MPNST. So hard to tell. So anytime I see a solid enhancing lesion, my report is solid indeterminate lesion. Let's get a biopsy, unless I can tell more. So how can you tell more? Well, there are different ways of doing it. You can do ultrasound Doppler, you can do diffusion, you can do DTI, withdraw these tracts, do ADC values with that, CT perfusion, this case lent to me by Dr. Blum. You can do ASL, arterial spin labeling of this leiomyosarcoma. You can do MR contrast perfusion, you can do PET, or you can do spectroscopy. I've tried all of these. But I think of all of these, this is what I like the best. And let's go through that. Well, it can show the tumors better. It can differentiate solid versus cystic. It can differentiate malignant versus benign in many cases, although there's some overlap. It can help you guide the biopsy. It can grade sarcomas, which we published recently. It can help tumor response to treatment. Everything which has been published for other tumors, nothing unique for MSK, but people are hesitant still to apply them. It's an easy sequence to do. So here is a lesion close to the AC joint. Is that a geyser phenomena? Hard to see good communication, but yes, that's what it is. It's bright and bright fluid, nothing else. Here you have big lesion in the foot, really dark, and you can see on perfusion some neovascularity, and that tells you it's tumor blush. So this is synovial sarc, and they really have low ADCs. Our pathologists do not believe that any synovial sarcs are low grade. They're all high grade, and they all have low ADC values, anywhere from 0.6 to 0.9. Here's another one. So now it's a big one. Is there another synovial sarc or MFH or pleomorphic sarcoma? What's going on? The ADC 1.6. But the lesion was so big, it's showing this early wash-in, sort of filled in the late image also, less washout. So this was a low-grade spindle cell tumor, grade 1 sarcoma. So what are the limitations? There is some overlap between benign and malignant, so you take everything together. Some benign lesions like hematomas can have low ADC, granular cell tumor we published in ulnar nerve, perineuromas can have up to 1.1, abscesses show low restricted, low diffusion. So basically you have to take it with a pinch of salt. Not everything is wonderful. Myxoid and chondroid tumors show less restriction. So here is a big tumor this lady came with. Somebody thought it's a hematoma, they drained it outside. And then it came to us. One of my colleagues actually called it a vascular malformation versus tumor. And then you look at this, it has some heterogeneous enhancement. And when we put the needle in, all this motor oil-like fluid was coming out. We thought, oh, maybe my colleague is right. But then I went all the way to the bone to biopsy, and finally we got the cells. It's a high-grade myxoid pleomorphic sarcoma. The ADC was 1.6. So again, did not restrict much. That's what myxoid and chondroid do. Here, is it benign or malignant? Well, hard to tell. It's enhancing, solid indeterminate lesion. Look at ADC is dark. That's worrisome. It turns out this patient had more lesions other places. So this is a Rosai-Dorfman syndrome. Okay, again, it's a lymphoproliferative or histiocytic proliferative disorders. They basically can give you low ADCs. So it's hard to tell, is it really bad stuff or good stuff? Here you have three tumors in neurofibromatosis, a large tumor, which would be sarcoma. If you look at on PET imaging, that's where it's uptake. If you look at on ADC imaging, that's where it's the highest or the lowest ADC value. And if you look at pre and post contrast, you can see the contrast looks the same, but on DWI images, you can see more of the necrosis. So it helps you in treatment response. Here's another one, multiparametric MR. So this was the leiomyosarcoma. You can see the low ADC. You can see the wash in, wash out. And then when it was given chemotherapy, it looked like this. So not too much change from here, but on ADC, you can see very little left. Most of the white stuff is necrosis. That's on the arterial spin labeling. Same thing, less perfusion, only in that area. And patient came back after surgery. They took the whole thing out and came back with the same tumor. They said, what is this going on? Well, if you look at on diffusion ADC is a reverse effect. On DWI is dark, on ADC is white. So now we're just dealing with a hemorrhage. The physician, the clinician wasn't too sure, and this is a contrast imaging, by the way. You can see the peripheral enhancement there, not much in the lesion. They still ended up doing PET imaging, and again, it only shows peripheral uptake. And then my colleague aspirated liters of blood out of that. Okay, so it's good for treatment response, and it has been shown that the ADC minimum has proportionate response rate similar to what you'll see with SUV max on PET imaging. So ADC is pretty good. So if you're doing something for anatomy, you better assess for functional response of the tumor as well. So here is a recent case. You can see there is a lesion there, which was MPNST resected. Now is a recurrence of MPNST, So all of this area is white, and there was a heterogeneous enhancement all over. But if you look at on ADC, this is the area which is the area of problem. And that's what we biopsied, and that was positive. The ADC is 0.8. So MPNSTs are very low ADC values. Okay, final 5 minutes or so, we'll finish up with neuromuscular lesions. So again, you can read it later. I don't have time to go through all this. But basically, early detection of denervation changes is possible on DWI and ADC. Here you can see the high ADC value of 1.6 enhancement in the muscle. You have a hard time picking that out on T2 images. Myopathy can be detected. So here two muscles look like bright, this one and maybe that one. On ADC, all of them are abnormal. All of them are green. So we're getting into 1.8 here. That's a proven case of myopathy. And within denervation changes, this white muscles, you can also pick out abscesses. So this is white and dark. Another case of myopathy, all muscles are abnormal. So this was a dermatomyositis. So in this case, all muscles are bright. So in fact, you can now measure the fat also. We published that one. You can measure the fat on treatment. You can look for the resolution of this stranding in dermatomyositis and going back to fibrotic changes. Nerve selective images are possible. We did DWI, but I don't use it for that because you can see them very well on anatomic images. Why do you want to see this overlap? Although we published that a while ago. Diabetic neuropathy or amyotrophy. In that case, you will usually see from L3 through S2, usually L4 to S2 nerve. So the nerve which comes at an angle is L5 nerve. This is 4, that's 3. So you'll see asymmetrical neuropathy here. This nerve is abnormal. These 3 are abnormal. The femoral nerve is abnormal. The sciatic nerve is abnormal. So this is how it will show up on diabetic amyotrophy. And we often get referred these cases from EMG and neurologists where they are not sure it's radiculopathy or amyotrophy. That's what you will see with that. The nerves become conspicuous. Or a piriformis syndrome, where you'll see this L5, S1 bright, split sciatic nerve, and bright peroneal more than tibial components. So you'll see that stuff again on ADC maps. Failed back surgery, we see a lot of them. Basically, what you're looking for is thickening of the nerve, the preganglionic segment, and the signal going all the way down into the L5, into that portion of the sciatic. You can see all of that. And even the S1 is abnormal. So if you look at it on the diffusion images, they really become conspicuous. You can see all these nerves. Pudendal nerves, the tiny nerves stuck in that scar tissue, you will see these bright nerves on ADC, pretty easy to see. That's the normal nerve on the other side, and that's a bright nerve. So you can pick out these small nerves, genitofemoral, pudendal, etc. And that scar tissue, you can pick up the inferior hemorodal nerve as well. We put a little bit of diffusion in passive imaging to find these areas of injuries. So this is a branch of the median nerve which is injured, Sunderland class 3 injury, or in cases of occipital neuralgia, this is an enlarged greater occipital nerve. This is a case I sent to OCAD, I think on Friday. Here you can see this is a facial nerve. You can see the 12th nerve. You can see all of these cranial nerves. So this is the nerve which is going down, the hypoglossal nerve coming from here. So you can see all these nerves. Actually, sorry, let me repeat again. So the larger one is the vagus nerve. The medial most nerve is the 12th nerve, which comes like that. And then spinal accessory, you'll see it going like that. So you can find all these nerves. So what we are looking for here is, this is a greater occipital nerve. That's abnormal. This is a normal one, hard to see. Okay, so that's the greater occipital neuralgia. So again, you can see it here. The lesser occipital will show up here. It barely shows up. On the other scans, it showed up. This is the normal one here. The least occipital will be in the middle. So you can see all these nerves in migraine patients and all. So this patient had that diagnosis. PNSTs, hard to tell if it's benign or malignant. When you see stuff like that, both are benign. These hemorrhagic changes are also benign. These are schwannomas. And these are red tumors with most of the tracts preserved. This is another red tumor. That's a neurofibroma, even if it's a dominant tumor in that neurofibromatosis. And these have less tracts preserved. This is a perineurioma in an older patient. Again, a red tumor. It's a benign tumor. Now, this obviously is malignant because it's a large tumor, ugly, heterogeneous in NF patient. Versus this kind of tumor, very hard to tell what's going on. Although you can pick out tiny bit of peritumoral edema, that was it. So this was a grade 1 MPNST, and these become blue tumors like that. Make sure your contrast scale is correct, because the contrast scale is reversed. So in this case, the bladder is white, the bladder is blue, the lesion is blue. That doesn't mean it's malignant. This is just a ganglion along the superior gluteal nerve. Okay. So Adam, do we have 5 minutes or should I stop here? Because I wanted to show what's possible in MSK. There's another 5 minutes of talk. I don't know. It's up to you. Huh?
Go for it.
Okay. So fiber tract images, again, this was published by Gustav. Like when you are at 1000 B value, you actually get good fiber tracts. So nerve sheath tumors, when they are perineuriomas like this, which are hard to biopsy in a young child, you can do tractography. First of all, you look at the ADCs 1.4, and perineuriomas can have up to 1.1. And if you look at tracts, you can see most of the tracts are maintained. It's a benign tumor. Versus this kind of tumor, there's more anterior near the spine where the ganglions are, and most of the nerves are passing around it. The ADC is high, 1.9, so we know it's a benign tumor. That's how paragangliomas look like. Versus a tumor, most of the tumors in brachial plexus come from C5, C6. So here is a tumor coming at around C6, coming from there, and 5 is displaced on the top and 7 is enlarged. So usually in that area, the tumors come in, and here you can see partially disrupted tracts. Again, high ADC value, it's a schwannoma. Versus this looks more ugly and has all disorganized tracts. The ADC was 0.8. We know it's a malignant peripheral nerve sheath tumor. The lymphomas may look like this, where the nerves are thickened around the tumor. You can see this nerve thickening. When you do the ADC, they're really dark. They're 0.6. They're round cell tumors. So easy diagnosis to make that way. Or sometimes they're like this, just nerve thickenings, nodular thickenings. And the tracts are mostly maintained because the tumor cells go around the nerves, disrupting the tracts partially, but most of the tracts are maintained. That's how lymphomas are, perineural spread. Versus this one, bilateral thickening, symmetric, so we know it's Charcot-Marie-Tooth disease. So they may have, if it's a thickened nerve with thickened tract, a little disorganized, we know it's CMT1A. Versus if it's a mildly thickened nerve with not much tracts there, we know it's CMT type 2, where you have more axonal degeneration, more loss of tracts. Here's another perineurioma. Again, most of the tracts are maintained, low ADC value. Now, we are also doing pre-surgical mapping for trauma and patients who have robotic hand replacements where their nerves are connected to robotic hand. One of our plastic surgeons has a DOD grant on that. So we image for that, and then he's looking for how far down you can see the nerve, how big is the neuroma, which nerves are preserved, which nerves look better. So here's a median nerve neuroma, and that's the area of the stump. And you can see most of the tracts are maintained. And he also gets electrophysiology for that. So this nerve is functional. He could connect to that after cutting through the neuroma. You can do injury mapping also. So this was published by Gustav et al. We did it together. So here you can see the inferior alveolar nerve through the jaw with the tracts. This is from the ultra-short TE imaging. So here we have Munilu, and this is a Zurich group. They did it together. I was just partly involved with that. But basically with ultra-short TE, you can generate the skin, bone, all these images and show the nerve on the top from one single scan. And right now we're doing it as part of our grant also. With entrapment neuropathies, you will see this enlargement of the nerve, scarring around it. You will see bright nerve on DWI or DTI. And then this is a normal median nerve. This is how the tracts will be missing if there's more of the axonal degeneration. And these are the remaining normal nerves. Failed back surgery I showed you, so let's leave that alone. But on DWI, you will see on the zero gap images, you'll see this abnormal preganglionic segment where they nick the nerve most commonly during discectomy. Ischemia can show abnormalities. So this patient had, this is the ulnar nerve, which is abnormal. Patient had more ulnar neuropathy, it's sickle cell disease. So you can see the whole marrow is abnormal. Okay, that's the ulnar nerve. And if you look for tract, there are not many tracts in ulnar nerve. So you know that's a problem nerve. So there's axonal degeneration from ischemia. Final couple of slides on whole body MRI. You can use it for a number of things. But basically this we reported a long time ago. It's almost a decade, can't believe it. You can see these schwannomas with cystic changes. These are normal nerves in the brachial plexus, in the lumbar plexus, and this is Charcot-Marie-Tooth disease with a lot of thick nerves. And you can grade the burden, you can look for entrapments and all that stuff. So you can do all the neuropathy mapping. Final slides on pitfalls, technical pitfalls. Again, you can look at the video again. Interpretation pitfall, bunch of them, just a couple of images. When you have a bad DWI image, when the patient is off center, like in this case, there's a lesion in the radius which does not suppress out, but it looks like dark on T1. It enhances on contrast, there's some periosteal enhancement. And if you look at on DWI, which is distorted because patient is out of field of view, it may look like bright. So we can't trust these values. Versus the same patient also had this upper arm imaging also. And here you can trust it because now you have a good signal on DWI. This is a very dark lesion. This was lymphoma. And I think this is the last slide. Here you can see a lesion which is organized, which is very dark. That you may think of as an abscess, but this was just a hematoma, which is organized hematoma. And that's another one at the plantar fascia rupture site. You can see hematoma like that. And you may think of tumor if you just look at DWI ADC. This is just a hemorrhage at the plantar fascial rupture site. All right, I'll stop there. Sorry, I went over a little bit because I want to show what's possible in MSK, and all of you young guys out there can do research, pick up any domain of that, and there's much more to do.
Thank you so much, Dr. Chhabra. Just because of time, I'm going to limit just the questions to one that came in, just because it was a technical question. Can you explain a little bit of the extent of IV contrast causing signal loss in DWI from relaxation effects?
Yeah, that's basically the same effects you observe when you give contrast on T2-8 images. So if you give contrast on T2-8 images, we don't use T2-8 images because you lose signal. And DWI is nothing but a heavily T2-8 image. Like even your steady state sequences also have a diffusion weighting. That's why even if you do your PCIF image or one of these DES images, they have vessels suppressed out because they have those diffusion effects. It's just as physicists, we name it differently, but it's similar effects happening. You get to a place of steady state where it's more T2 effect and you don't get any signal. So similarly, you know, people who have problem doing neck imaging for brachial plexus, they'll actually give contrast first. Like there are Japanese studies out there where they inject the contrast and they do brachial plexus. You can see the nerves better.
Got it. Thank you so much. And again, thank you so much for your time. If there are other questions, which I think some of them come in, and I've seen people raising their hands, Dr. Chhabra's email is on the screen here. So please email him with any additional questions. Have a good day, everyone. And thank you so much. See you next week.
Okay. Thank you, Adam and Emory team.
Thank you.